all right, CAR T cells, how do we make them, and how does this work? There's two ways of modifying T cells. One is to actually put a T cell receptor into the T cell, and the second way is actually to modulate the T cell by putting a CAR. They're fundamentally quite different. The T cell receptor requires HLA restriction. It's only good for intracellular targets. And the real breakthrough came when people figured out you could use an antibody to retarget the T cell. And the studies Ollie Press did in the very beginning days were with the thing on the left there on the bottom. These are cells that essentially have a first generation CAR, and they didn't work very well. And then people moved to a second generation CAR, which is shown in the middle there, with either a CD28 or 41BB co-stimulatory domain, and suddenly CAR T cells became very active. And we started seeing responses in lymphoma and leukemia, and that's really formed the basis of the two commercial approvals that have happened to date. We also have third generation CARs in the clinic now, but it's not clear whether those are actually better or not compared to the second generation. So I'm going to first just say a word about some of our trials in Seattle. These are homegrown CAR T cells that we're using in Seattle. These studies are supported by Juno Therapeutics, and we developed a second generation CAR with the anti-CD19 variable region linked to 41BB and the internal signaling portion of a T cell receptor. And the way this was done was patients underwent a leukapheresis. We actually selected CD4 and CD8 cells separately, made two CARs, and then formulated them back in a 1-to-1 ratio. So why did we do that? Well, we had laboratory data that suggested that patients have a wide variety of CD4 and CD8 cells in their blood based on their prior therapy, and that by selecting two populations, we could give a more defined population. And we believe that this gives us a better relationship between dose and toxicity and dose and response. All the patients receive lymphodepleting chemotherapy, and I'll show you that's critically important about what type of chemotherapy you use, and that's true for the field. And then patients receive their CAR T cell infusion. This was initially a feasibility study, and there was really no eligibility criteria based on lymphocyte count, circulating tumor, or prior transplant, and all you had to have was a relapsed refractory B-cell malignancy in several different categories. And I'll focus on lymphoma and a little bit on CLL today. So here's the data on 41 patients with lymphoma, a wide age range up to age 70. The largest cohort was diffuse large B-cell, median of 4 prior regimens, and 19 patients had failed transplants, either auto or allo. And we used a variety of lymphodepletion regimens, and I'll show you some of the data about that. And we were able to grow T cells in virtually 100% of the patients. First thing I would point out is it's critically important how you give lymphodepletion. So what does lymphodepletion do? Lymphodepletion makes an environment that's rich in cytokines that can actually enable the T cells to grow and persist. Remember, this is a living therapy, and whatever the doses we give you now, we anticipate that those cells will grow over time, and they need to expand. In fact, the response is correlated with the ability of the CAR T cells to expand. And if you use fludarabine, you have a much greater expansion of both the CD4 and the CD8 cells. And this is because there's a higher IL-7 and IL-15 after the lymphodepletion, and that leads into longer persistence of the CAR T cells. Longer persistence of the CAR T cells leads to better effects, including complete remission rates. So the response rates, when we finally got to Cy/Flu, again, about half the patients were treated with Cytoxan alone, but with Cy/Flu, you can see the response rates are in that 80% range, with complete remission rates in the 40 to 50% range in a variety of histologies. This is just a dramatic example of a pleomorphic mantle cell lymphoma that actually relapsed and was refractory to an allogeneic stem cell transplant, in complete remission now more than 3 years later with relatively little toxicity. In general, it's important to get a complete remission, and if you get a complete remission, the survival is quite good. For patients with less than a complete remission, they generally go on to progress, although I'll show you some exceptions in the more recently updated commercial products. But there are relapses, and some of these relapses can actually be from CD19 negative tumor, or they can be from loss of CAR T cells due to an immune response against the actual CAR. Now, these regimens are also quite toxic, and the two toxicities that you need to remember about are cytokine release syndrome, or CRS, and the other one is neurotoxicity. This cytokine release syndrome occurs in the majority of patients treated to some degree. In our study, it was about 63%, and it was mild to moderate in about half of those, but it was severe in about 13%, and we had 2 deaths in the dose escalation phase of the study. And this is predominantly associated with high fevers, vascular instability, and often patients need fluid support or even pressors in the ICU, and rarely this can progress to requiring ventilatory support or even dialysis. The second toxicity is this neurotoxicity, and this is really one of the major issues in the field. We don't completely understand this. We just published a paper last week in Cancer Discovery looking at 130 or so patients, and we think that this is due to actually vascular toxicity and endothelial cell damage from cytokines, leading to a breakdown in the blood-brain barrier and access of cytokines into the CNS. I really don't have time to present all that data, but it really point you to look at that paper. This neurotoxicity is grade 3-4 in about a quarter of the patients with our product, and it can either just be confusion or inability to find the right words or to talk, but it can progress to encephalopathy and even cerebral edema and result in patients dying. If you get the dose right, the incidence of severe CRS, meaning ICU care, in our series in lymphoma was only around 10%, and neurotoxicity was only 18%. But this is very product specific, it's very signaling domain specific, and you need to look at each of the different products to determine the safest dose and the safest way to give the cells. But this is very important. This requires a center that has experience with this, and neurotoxicity and cytokine release syndrome can be life-threatening, and patients need to be managed for at least the first 4 weeks very close to the center. The other point I'll make here is that the onset of severe CRS correlates generally with its severity. Here you can see that people where we had severe grade 4-5 cases, there weren't very many, but they had very almost instantaneous onset of CRS and was often associated with the dose, whereas patients with more manageable grade 1 to 3 CRS or no CRS. The other point I will make is that the neurotoxicity comes on later than the CRS. Typically, the CRS is occurring fairly quickly in the first few days. Neurotoxicity can have a lag of several days behind that, median onset closer to 4 to 5 days in our series. So I'm going to conclude about our studies at the Fred Hutch that this has potent activity in ALL, NHL, and CLL. I'll show you a little data on CLL at the end, but the response rates in ALL have been about 95% complete remission rates. This defined composition is feasible, and we believe that it's important, but there's never been a randomized study comparing this to other non-selected approaches. We have shown immunogenicity against the CAR. These CARs have a murine single-chain FV, at least the ones we're using now, and you can make an anti-CAR T-cell response that rejects your CAR T-cells, and if that happens, you can't retreat the patient. And even if you give them fludarabine, you try to retreat, and the T-cells are rejected. So their T-cell immune response rejects their modified CAR T-cells, and this is a problem in all of the series using murine antibodies. The question is, could you use a human antibody here? Possibly, and there are studies ongoing. The lymphodepletion is critical. I think, and we think, you need to use fludarabine to improve persistence, but that persistence and the expansion is directly correlated with both toxicity and with activity. So there are some ways around this. You can do scheduled second infusions, or you could use checkpoint inhibitor antibodies, and all of these things are really ongoing. And we also believe that you can detect CRS as soon as 24 hours after treatment, even in asymptomatic patients. And this might be able to pick patients at the highest risk to allow interventions to mitigate. And so I'm now going to talk about that product, Axicabtagene ciloleucel, known now as Yescarta, is the first commercially approved CAR T-cell product for large cell lymphoma, and it was just FDA approved last month. And this is a second generation CAR. It has the single chain FV against CD19. It has, again, the signaling domain that's different than the one I was talking about from the Hutch. This is a CD28. And they did a study comparing this essentially in historical to the SCHOLAR-1 trial, which is also just recently presented, as we've heard about. The response rate was only 26%, with a CR rate of 8% in that historical group, with a survival of around 6 months. So this was a phase 1, phase 2 study, but this was in aggressive lymphomas, diffuse large B-cell primary mediastinal or transformed, chemo-refractory disease, meaning no response to last chemotherapy or relapse within 1 year of an auto transplant, prior CD20 and anthracycline, and this is really important, ECOG performance status of 0 or 1. There are no ECOG performance status patients of 2, and many patients with refractory diffuse large B-cell lymphoma are in that poor prognosis group. Primary endpoint for the phase 2 trial, now once the safety was established, and the dose escalation was to get into refractory lymphomas, and that's the data that was presented to the FDA. So this is a group of patients. They're very heavily pretreated, and you can see relapsed refractory large cell or the combined primary mediastinal or transformed follicular lymphomas. Again, lots of prior therapies, and a generally age range up to 76, although there's a relative minority of patients treated over the age of 65. This is the bottom line that came from the clinical trial. The overall combined response rate, the overall response rate was 82% with 54% complete remission, and I'll show you the updated data from the FDA analysis in just a second. But you can see across the range, the overall response rate's about 80%, and about half of the people have complete remission rates. And very important, you saw this slide before, but this is a complete remission rate with a median progression-free survival not yet met in a duration of response. And it's important to have a complete remission, but I will point out that some of these partial remissions on the initial look do convert to complete remissions, because this is a living therapy and you can look too soon, and even at about, I think at 1 month, 20% of those people went on to, of this eventual CRs went on to a complete remission. The adverse events seen with this are significant. You can see most people do have adverse events of grade 3. The CRS of grade 3 or greater was a relatively low number of patients. Grade 3 neurotoxicity, also about a third of patients, so maybe a little higher than what I showed you before. Relatively rare grade 5 AEs. Now, I will point out that the grade 2 CRS is no easy feat. So grade 2 CRS can allow you to be in an ICU on pressors, and so I think this is a bit misleading, and these people need to be monitored very carefully. These are largely reversible, and about almost 40% received tocilizumab, and 27% required steroids in addition. And so this requires tocilizumab to be on hand, 2 doses per patient at the center at the time you treat the patient. So now this is just FDA approved last month. The actual indication is a little bit different than what I showed you from the clinical trials. The indication is relapsed refractory lymphoma this is from the clinical trial, but the actual updated data is for patients with 2 or more prior therapies. There is a REMS program, and it requires, the treatment also requires Cytoxine and fludarabine. as conditioning, a little bit higher doses than what I showed you before. There is a black box warning as expected. It's shown here, cytokine release syndrome and neurotoxicity. And this, again, is very important. So it's now approved for relapsed refractory large cell lymphoma with 2 prior therapies. Again, shown here. And the histologies include large cell lymphoma, primary mediastinal large lymphoma, high-grade B-cell lymphoma, and transformed follicular lymphoma. So again, this is very exciting times. This is now going to be commercially available. Sites are being site visited now to get this updated and get up to speed. And hopefully this will happen very soon. This is the data from the FDA, overall response rate 72%, CR rate of 51%. So those were the answers from the study on those questions. The duration of response has not been reached for the CR patients. So this is, are these patients cured? We don't know yet, but in the studies preceding this, patients have been out as long as 5 to 6 years. All right, that's not the only kid on the block. There is the Juno JCAR-17 product. It's also defined as CD19. This is based on the work we've done at the Hutchinson Center, and it separates the cells into CD4 and CD8 populations and gives back an equal mixture of cells, and it has a 4-1BB construct rather than a CD28. And this does seem to have some difference. This was a patient characteristics of the large cell lymphoma cohort that was reported at ASCO Lugano and updated last at Lugano. And in the dose level 2, you can see about 50% of patients had complete remission rates, a little higher, and about 80% of patients have overall responses. So this is very, very exciting. There were a couple cases here that were written up as case reports with CNS involvement that had complete resolution of their CNS disease. So this is no longer a criteria for the Juno trials to have CNS involvement, but it's an exclusion from the Kite trials. And again, you can see CRS seems maybe a little bit less in terms of the incidence at all dose levels. And the neurotoxicity might be a little bit less. This is a swimmer's plot showing, again, long remissions in some of the patients, but relatively short follow-up. Then the third product in the same space is CTL019. This is the Novartis product, and this is the same single-chain FV, and there's a 4-1BB co-stimulatory domain, somewhat similar to, again, the Juno product. This really has shown almost identical data. This was the patient disposition on the trial. They enrolled patients on a separate trial for collection and then actually ran into manufacturing issues and only were able to treat 85 of these patients and had quite a few patients die before they were able to treat them. And this is obviously a problem with the field. But with this approach, again, about 60% of patients responding and 43% having a complete remission rate. And so the CR rate at 3 months was around 37%. So again, are these patients cured? We need a longer time follow-up, and this is the data you saw from the JULIET duration of response for the CRs. Again, cytokine release syndrome is the major issue and neurologic events. I will point out this is a different scale than everyone else uses, so it's a little bit difficult to compare numbers, but it's a very exciting new agent as well. Everything is basically the same as what I showed you for the other 2 products. Patients do require tocilizumab or corticosteroids if they have disease. So I'll summarize the NHL landscape shown here. Obviously, we have Kite CD19 now approved, and it has a response rate in that 50% range with a CR. We have Juno and Novartis products in the same ballpark. These are different products. It's very important to note that this is a CD28. These are 4-1BB co-stimulatory domains, and there's different populations of T cells that are used. and the toxicities are likely to be different. Now, in the short term, this is probably not going to make a big difference, as we only have one product approved, but eventually with time, I think obviously these products will be selected based on their duration of effect and their toxicity profiles. I will just say a minute or so about CLL. This was just published in JCO about a month ago. We've treated 24 patients with refractory CLL. These are ibrutinib refractory in 80% of the patients, very high risk, often with Richter's, and having very FDG avid disease on PET scan in 93% of the patients. So you could argue with this is not CLL anymore, but it's clearly CLL in transition. We were able to grow T cells in all these patients and treat them. I will just summarize all the data here. If you just look at the patients who now got Cy/Flu lymphodepletion, whether they were, 19 of these patients were restaged. These are all patients or the ibrutinib refractory patients. You can see the overall response rate was in the 74%, and the CR rate was relatively low. But this is in largely part because of CAT scans. It's very hard to have a 12 centimeter mass go to less than 1.5 centimeters on a CAT scan because of this just resolution of scar tissue. But you can see 88% of patients were completely flow negative in the peripheral blood and bone marrow at 4 weeks. So this is a tremendously active treatment. If you incorporate PET scan, you can see that the CR rate goes up to closer to 64%. And the other thing we've observed is that if patients get in, have responsive disease, whether you call it a PR or a CR, that they do generally well. The survival is better in that group compared to the group that did not have at least a PR. And this is very exciting, and we're hoping to move this forward into trying to clear patients' blood and bone marrow and put them into molecular remissions and hopefully maybe cure their disease. We found that if you use deep sequencing, you can identify patients who are deep sequence negative early on, and they seem to have a better outcome, and it may be another way of monitoring these patients. So I'll conclude here. There's a high response rate in ALL, CLL, and non-Hodgkin's lymphoma, but we have 2 FDA approved targets or targeted agents for CD19. This is in the Novartis product in ALL and the Kite product in NHL. This is very exciting. Response rates appear way better than historical controls, but I'll also agree with John Leonard, there is a selection bias. The patients have to live long enough to get the treatment. We need longer duration of follow-up to determine whether this is truly curative. And there are a lot of logistic difficulties in bringing this individualized treatment forward into mainstream cancer therapy. The cells have to be produced in a reliable and rapid turnaround, and I'll have to say that the Kite approach can do this in 17 days, and this is certainly very reasonable. Distribution will ultimately need to be worldwide. The treatment needs to be done in specialized centers, and the patients have to be managed for severe toxicity. This represents a new treatment option for patients with refractory disease and will likely move up as physicians and regulators become more familiar. Cost reimbursement needs to be worked out. This is a big deal. You've been reading in the press. But I will point out that triple drugs, as we heard from Dr. Gilmini just a minute ago, for a year is likely going to be more than the cost reimbursement for the price of CAR-T cells. So I will conclude here. This is our new clinic, the Bezos Family Immunotherapy Clinic, dedicated for cellular immunotherapy. And it's very exciting for me to be the medical director of this clinic. And I'll thank all my collaborators, including our lymphoma group. Thanks so much.